Okay, so we're live now. Good evening, everyone. Thank you all for joining us today. This is the third day of our event, FEN YISHI. The purpose of our event is to spread awareness among people about breast cancer. Okay, so let's get started. I welcome Asia to welcome the gathering.
A very good evening to one and all gathered here. It gives me immense pleasure to welcome you all on behalf of South Indian Medical Students Association to this webinar on breast cancer awareness, FEN YISHI. FEN YISHI is a 3-day awareness session on breast cancer conducted by SIMSA, Tamilnadu. I am honored to welcome Dr. 𝗪𝗻𝗛𝗵𝗏, a consultant surgical oncologist of 𝗥𝗲𝗵𝗀𝗀 Cancer Center, Chennai, and also working in Shifa Hospital, Tirunelveli, who took valuable time off his busy schedule to join us today. In this webinar, we would be throwing light on recent advances in breast cancer, its diagnosis, treatment, and rehabilitation. The difference between hearing and learning is paying attention. So let's all listen and learn together.
Hello, good evening. Can I start?
Yes, please, sir.
Yeah, thank you. So I first congratulate the students from the SIMSA, so who have taken great effort in conducting this awareness program online in spite of this pandemic, and they have selected very nice topics. So we had two interesting topics yesterday, and today we have got a topic which is innovative, that is on recent advances in the diagnosis, treatment and rehabilitation of breast cancer. I thank the organizers for giving me this opportunity, and thanks for introducing me to the medical fraternity. I congratulate and convey my best wishes to all the students who are hearing this through YouTube streaming as well as through the Zoom. So before starting this session, I would like to put a disclaimer, like this is mainly recent advances. So you won't be finding these things in your regular textbooks, and do not try to use these informations to clear your examinations in your MBBS. So it is for your information to increase your curiosity and to bring out new changes in the management of breast cancer. So this is Pink October. So this FEN YISHI, which means pink awareness. Even though we celebrate October as the Pink October as the awareness month for breast cancer awareness should be around the year. So every day, every month, we have to be concerned about breast cancer, and we need to educate our fellows, our relatives, our friends, and the general public about the importance and the grave consequences of breast cancer, so that we detect the disease at the earliest point. So coming to the topic, so this is mainly on the recent advances. So before going to the recent advances, I would like to just highlight the cancer burden. So you all know, overall, the cancer disease per se, not only the breast cancer, the whole of the cancer is increasing all over the world because of various reasons, mainly changes in lifestyle, stress, and other things. But of all, breast cancer burden is the highest. So it is the most commonest cancer in women, both in the developed as well as in the underdeveloped countries. And the global death rate due to breast cancer in 2011, if you look at it, it is around 5 lakhs plus. So this is steadily increasing. And if you see, it increased to nearly 8 lakhs in 2019. And we have got a lot of disability associated loss of ear also because of these things, this breast cancer. So not only in worldwide, even in India, we have got an increase in the breast cancer. So previously, India was predominantly semi-rural or a rural country, but still previously it was cancer cervix as the most commonest cancer among females in rural areas. Only in urban areas like cities, we had breast cancer as the main cancer causing disease. But now, even in rural areas, we find there is an increase in breast cancer. So the statistics, which is very staggering, is with every 4 minutes, an Indian woman is diagnosed with breast cancer. So this is really thing which we have to be worried about, and it is in rise both in the rural and as well as in the urban areas. So women can self-diagnose because breast cancer is one which happens in an organ which is externally, which is just in the subcutaneous region, which can be easily touched, seen or palpated by the person herself. So it has to be diagnosed very easily by the patient themselves. So that is the reason why this breast self-examination, even I think that was also a topic in the day one. So this breast self-examination is one of the easiest and it's a cost-effective method by which a person, a lady, can identify whether she has breast cancer or not. So this has to be done, and which it will definitely reduce the breast cancer burden. So coming to the recent advances, even though there are a lot of recent advances, still triple assessment is the standard. So you all know what is triple assessment. It is a clinical examination of the breast. So the clinical examination will be done by a clinician. Next is a non-invasive imaging. So the non-invasive imaging, usually it is a mammogram. So the mammogram will be done if the patient's age is above 35, and if she is below 35, we can go for an ultrasound of the breast or an MRI of the breast. The reason is we should use a non-radiological like a mammogram can be used only in a non-dense breast. In younger ladies, it will be a dense breast, and mammogram may not be of useful. We may miss some lesions. So that is the reason why we have to go for a sonomammogram or an MR mammogram. That is a MRI. And the next is we have to go for an invasive technique. So the invasive technique is a histology. So usually we do a FNAC, that is fine needle aspiration cytology, or a true cut biopsy. So the thing is, like, first we have to do a clinical examination, followed by a non-invasive method, then followed by an invasive method. This is the order of the triple assessment. So I can see even in my experience, there are some places where FNAC or a biopsy being done before a mammogram. That should be definitely avoided. The reason is always a non-invasive method has to come first before an invasive method. And another reason is when you go for a invasive method, like you do a biopsy or an FNAC, it produces undue hematoma or bleeding in the breast, which can definitely change the architecture in a mammogram. So always precede the mammogram before an FNAC. So now we have got recent advances. So the recent advances are, we have got more screening modalities are there. Mammogram is available freely everywhere, and even MR mammogram is there. Sonomammogram, that is ultrasound mammogram, is there. Even PET scan and PET mammogram is there, and there are a lot of risk assessment tools. So coming to the risk assessment tools, what are these? These are all several models by which, for any female listening to this symposium or the webinar, they will have that doubt whether we will get breast cancer or not. So there are a lot of models put forward by various people. So the most commonest and historical one is the Gale model. So it considers the non-genetic factors and takes into account family history to a limited amount. And there is something called a Claus model, which takes into account the age of the patient and the first and second degree relatives who are affected by breast cancer, and those age, that is the disease, the age of onset of the disease in those relatives. So this brings forward the Claus model. We have got another model which is recently updated, is the BR-CAPRO model, where genetic mutations, there is a BRCA1 and BRCA2 mutations are also included, along with the penetrance in mutation. There is another model which brings into the benign breast diseases also, and also the estrogen exposure. This is called the Cusick-Tyrer model. So these are all various models by which we can assess the risk in which a lady may develop a breast cancer or not. So another thing is, we have come across a lot of molecular typing. Previously it is just a breast cancer, and we had a lot of histological variants like invasive ductal carcinoma, then invasive lobular carcinoma, comedocarcinoma, then tubular carcinoma, medullary carcinoma, like that. But now it is basically the molecular signature. So that is, we have classified into luminal A, luminal B, HER2, and triple negative, or the TNBC. And this will come into elaborate discussion later. So this is the different things. In luminal A, it has a good prognosis. Luminal B has a next prognosis. And triple negative, where all the three are negative, that is the estrogen receptor, progesterone receptor, as well as the HER2 neu receptors are negative. And another thing is the HER2 positive, that is HER2 enriched. So what is this how did they come to this classification? It is based upon the cell of origin, or from which the cancer cells which resembles which cell of the ductal epithelium. So this picture explains how they are being classified. It is basically the molecular signature of the cancer cell. So when we come across what is the different proportion of these cancers, we can see the ER positive, that is estrogen receptor positive and HER2 negative cancers accounts to nearly 60%. That is luminal A and luminal B, and triple negative comes to around 20%, that is ER negative and HER2 negative, and HER2 positive cancers comes to around 15 to 20%. And why we have so much classification is, it not only differentiates the treatment modality to be done, but also it prognosticates the tumor. So in this picture you can see, as the triple negative and HER2, it is worse prognosis, and if it is a luminal A and luminal B with positive hormone receptors and negative HER2 receptors, it has a better prognosis. So the difference has caused a change in treatment, the difference in disease progression, and difference in metastasis and recurrence, and difference in prognosis. So how does it change a treatment? For example, if the patient is having a HER2 positive patient with ER negative, we will be definitely giving a targeted therapy like Herceptin or the trastuzumab, and we won't be giving any hormonal treatment like estrogen receptor or progesterone receptor blocker. So previously, all the patients of breast cancer will be treatment with the hormonal receptors. They will undergo oophorectomy, irrespective of whether the cancer is estrogen or progesterone receptor positive or negative. So now, because of these molecular signatures, we have caused a change in the treatment modality. And next thing is the difference in the disease progression. We all know this luminal A, luminal B has a better disease progression when compared to HER2 new and the triple negative. So all these cases, they may develop metastasis early, metastatic recurrence can happen, and even the predominant organ in which the metastasis happens also differs. For example, in TNBC or HER2 positive, we may get more of visceral metastasis, brain metastasis and all. But when compared to other ER positive and PR positive tumors, they may develop bone metastasis. So even the metastasis preponderance also varies based on the molecular signature. And as I have already mentioned, it also prognosticates the disease. A ER positive tumor or a PR positive tumor will definitely have a better prognosis when we compare with a triple negative cancer or a HER2 positive cancer. So coming to the advances in breast imaging, we are discussing breast imaging as the second clinical of the triple assessment. We have got imaging. So the first advance is the full field digital mammogram. This is called FFDE, and we have computer-aided detections, dynamic MRI, PET mammogram, molecular breast imaging, breast thermography, and breast tomosynthesis. So I am again reiterating here, you may not find these things in your textbooks, and do not tell about these things in your viva or in your clinical examinations and all. So this is for your information and to increase your curiosity. So what is this full field digital mammogram? In short, this full field digital mammogram is nothing but like a digital picture which we take in your digital camera or in your Android phone. But the regular mammogram is like a printable photo which you take in your film roll enabled camera. So that is the main difference. So here, instead of the X-ray film, image is being captured by solid state detectors. So they are converted into electrical signals. So what is the advantage? So we can produce various images of the breast on a computer screen, and if we want, we can print it in a film, and we can increase the intensity, decrease the intensity, and alter the things to assess the architecture of the breast. So this is the advantage of digital mammogram. Both use X-ray radiations only. Both have radiations. There is no thing like digital mammogram will not have X-rays. Both will have X-rays, but the conventional mammogram, they are read and stored on a film, but the digital mammogram are read and stored in a computer. So when the data is stored in the computer, we can enhance the data, we can magnify it and manipulate it for further evaluation so that our results will be more appropriate. So this is a picture of a full field digital mammogram. You can see there is a blue color ball. So that is a place where the breast is being kept, and we take the picture and it is captured in the computer. So what is meant by computer aided diagnosis? You all know about AI, that is artificial intelligence. So we all are intelligent. So we are increasing our intelligence to our convenience by helping and creating artificial intelligence. So this CAD or computer aided diagnosis is again a type of artificial intelligence. So we got a lot of mammograms, lot of patients and who come to us. So previously it is a manual person. Even though we have a full field digital mammogram, a person has to see the mammogram. A radiologist have to see the mammogram and identify whether there is a lesion or not. So there is a manual thing happening. So in computer aided diagnosis, so there is a algorithm being followed. So here what they do is, if there is a mass lesion, they enhance the mass lesion. They enhance means the computer enhances by using filtration. So after filtration, they identify the suspicious region and localize it and segment it. So after that, they examine the shape, size, texture of the thing, and this is called feature extraction. So once this is done, they select the feature and classify it as a false positive or a false negative. So with this, we can, for example, if a radiologist is doing daily 10 mammograms, with this thing, you can increase it to 100 or 1000. And also it will be more accurate when compared to a manual. And there is the radiologist may get tired, they may not pick up one thing, some lesions may get missed, but in this computer aided diagnosis this can be nullified. So this is the advantage. You can see here same mammogram, a fully digitalized mammogram which was read in 2007 and it was read manually and has been classified as benign, and it's again read in 2009 again as benign, but in 2010 it is with the use of CAD, that is a computer aided diagnosis, it has come out as a malignant lesion. So this is the advantage of having a CAD. It increases the number of cases you see as well as increases the accuracy. So coming to the next advancement is the dynamic MRI. So it is like a functional MRI. So you all know MRI means magnetic resonance imaging. So you all know it is a non-radiation technique. So you all know about MRI. It's usually a static MRI. So what is meant by dynamic MRI? So here the dynamic MRI is done by taking T1 weighted acquisition images between 5 and 7 minutes after contrast. How the tumor or a mass lesion reacts with the contrast material. So you all know the characteristic feature of malignant cell is, the malignant lesion is, they will have vessels which are immature. So when there is an immature vessel, the vessels will be leaky. So they will have a lot of gaps. So because of the gaps, the contrast will leak early and again it will come down. So this is the reason why we can use this as a method to identify benign and malignant lesion. So here I'll showing this picture. This is a MRI washout patterns. So you can see in the normal area there is no pickup at all. You give a contrast, the contrast is not being picked up by the normal tissue. So when there is a lesion, it attracts the contrast get enhanced in the images. So in case of a malignant lesion, there is early washout. So the image becomes normalized after some time. But in case of a benign or an intermediate, there is an increase or there is a plateau phase. So this is an advantage of the dynamic MRI. So this MRI has improved our pickup rate of lot of malignant lesions, and this MRI has helped us in very dense breast, as I already told, where regular mammogram is not useful. So dense breast, breast with prosthesis, already operated breast, and young patients with breast lesions. So this is an advantage of dynamic MRI. Here you can see a picture. So here there are 6 pictures. The first picture you can see a lesion which is non-enhanced. Second picture non-enhanced. Third picture it is enhanced, and fourth the enhancement comes down gradually. So in case of benign the enhancement increases, but in malignant lesion it will gradually decrease. So this is the advantage of the dynamic MRI. Coming to the next thing is a PET mammogram. You all know about PET, that is positron emission tomography. So all these investigations are being done based on some of the chemical, physical or a biological property of the tumor. So for example, you have a fracture. So fracture in a bone. So bone is radio opaque. So that is a physical character. So when there is a fracture, that radio opaque bone appears broken in the X-ray. So we are using the physical character of the bone. So similarly, in breast cancer, we use a lot of characters of the breast. So in the previous thing, there is the MR mammogram. I was telling about the dynamic mammogram. There we used the character of leaky vessels of the malignant lesion. So here in PET mammogram, we are using the biochemical parameter. So what is a biochemical parameter? Here we all know malignant things use anaerobic metabolism. Even without oxygen, they can survive. So this is anaerobic metabolism being done by the malignant cells. So it is nothing but the positron emission mammography. It's a nuclear medicine imaging modality. Here again, it is typically refers to an X-ray imaging, while that is a normal mammography is an X-ray image, but in a PET mammogram, it uses an positron emitting isotope. You all know what is positron. Positron is a positively charged electron. So a radioactive substance. What we use here is a 18-fluorodeoxyglucose. So what is a deoxyglucose? So there, instead of oxygen, so deoxy, the oxygen is removed, and instead of that, we are placing a radioactive isotope that is called fluorine. So that fluorine will emit positrons. So this positron will be picked up by the sensors, and that will show us the image. So here you can see this is a PEM, or a positron emission mammogram. So here in the digital mammogram, you are able to see they are placing the breast between two plates, two sensors. But here you can see in this picture, a lady is lying down prone. So in that, there will be a gap for both the breast, and the breast will be hanging. Even in MRI also, we have that MRI in a prone position only. So here you can see there is a lesion in the breast. So you can see there is a lesion, and the breast is hanging in the prone position. So this is called the positron emission mammogram. Here we have to use a radioactive substance which emits this thing. So here you can see this is the conventional regular mammogram. Here you cannot see the lesion properly, but in a positron emission mammogram you can see the image clearly. So here again I am reiterating, these are all not regular investigations. These are all recent advances. Some are recognized as investigation modality in some countries. Some are still in experimental stage. Some are used only in research stages. So consider these as extra information to increase your curiosity, and it should not be followed routinely in our clinical diagnosis. Now coming to the molecular breast imaging, as I was telling you previously, we have, instead of injecting a radioactive substance, you can even inject other substance like technetium. So when you inject a technetium scan, you know about technetium system EB scan. So we get a molecular imaging of the breast. This is otherwise called as a miraluma test. So here in this picture you can see. So this is a miraluma test where the breast is being screened for the radioactive substance, that is after injecting the technetium. You can see and compare it with the conventional mammogram. So the advantage is we can even identify some of the second lesions or which are missed by the conventional mammogram. In this you can see there is a conventional mammogram on the left side, and there is a molecular imaging on the right side. So the second lesion is being missed in the conventional mammogram. So why this is very important? So if the patient, we are seeing this as a single lesion, we will be going ahead and doing a breast conservation surgery, removing the primary lesion alone. The second lesion we would have missed, and that second lesion will cause recurrence. So with this thing we can identify any second pathology. So this is an advantage of this thing. And another improvement which was there since 1960 is called as the breast thermography. So this is again a non-invasive thing. So what is the physical character here we are using? So we all know we all have a body temperature, regular body temperature. But if there is a malignant lesions, that body temperature, the temperature of the lump will be higher. For example, when we study about sarcomas, no, we always tell sarcomas, you all know it is a tumor arising from our muscles or from the soft tissue or the connective tissue. So when we touch the tumor, it will appear warmer than the other area. So why it happens as a warm area? Because the blood flows through that lesion is higher. So the blood flow is higher, so it is more warm. So similarly, in the breast lesion which is malignant, which is probably malignant, the blood flow will be higher and it will have a higher temperature. So this difference in temperature is used in this breast thermography. The advantage is it is very fast and it does not involve any radiation. It introduces, how do you use this? If you use high resolution infrared cameras to get the heat images. So this was there till from 1960, but still it is not used in most of the areas. But recent advances in the IR cameras, that is the infrared cameras, have helped us in identifying this thermography images. Now in some places, this breast thermography is being used as a screening modality. And also another advantage is we can even use it for treatment response. For example, in a patient who we are giving neoadjuvant chemotherapy, you all know what is meant by neoadjuvant chemotherapy, where we give chemotherapy before surgery to reduce the tumor size or to make an inoperable lesion as operable. So here in this, for after every treatment, you cannot take a mammogram, and it is difficult and it has a lot of radiation. So instead of having a mammogram, we can have a thermography. So here you can see there is a gradual reduction in the red color. There is a size of the lesion. So the treatment response can also be assessed by the thermography. So breast thermography, this is an advantage. So next thing is a breast tomosynthesis. So this breast tomosynthesis is nothing but a technique which produces 3D images. It is nothing but a 3D mammogram. You all know about 2D scan, 3D scan and 4D scan in the fetus. So to see the baby. So normally we say in maternal scans, we see the baby as a 2D image. We will not be able to identify. The radiologist will tell this is the eye, this is the limbs, like that. But in 3D fetal scan, you can easily identify the limb buds, identify the baby and all. So similar technology is used in this mammogram also. Here we use a 3D image with an X-ray. Instead of ultrasound, we use a regular conventional digital X-ray in a 3D. So with this, again the sensitivity increases. Here you can see the 3D image definitely increases the pickup rate of lot of malignant lesions in a small area, small size lesions and early lesions which may be curable. So for example, a conventional mammogram may miss that, but a 3D tomosynthesis will help us to identify those missed lesions. So this is the advantage. So you can see here, there is a 2D mammogram on the left side and a 3D mammogram on the right side. So the 3D mammogram gives us a three-dimensional image of the 2D mammogram. Here actually the mammographic plate moves in two axes, X and Y axis, and gives us the 3D image, three-dimensional image. So these are the various types of diagnostic modalities which have come up as recent advances. Now coming to non-palpable lesions. So nowadays we have got a lot of mammograms. So the mammogram pick up some lesion, but the lesion may not be palpable by the person. So we have triple assessment. So there is no lump. The patient has come for a screening mammogram only. So in the screening mammogram, you identify a non-palpable lesion, which is not palpable clinically. Now we have to take a biopsy or histological, that is as per the triple assessment. So we have to localize the lesion. So how to localize? So in other areas like in abdomen and all, we use ultrasound guided FNAC or CT guided FNAC. But in breast, we have got a technique called wire localization and roll. That is nothing but radio guided occult lesion localization. So this wire localization is nothing but we insert a wire using ultrasound so that the tip of the wire reaches the lesion, and we take the biopsy with the help of that wire. So we follow the wire and remove the wire along with the lesion and send it for, we can even do a specimen mammogram where we take a mammogram of the removed specimen so that to confirm that the entire specimen has come out and also how much margin we have given. So this is called as wire localization. So you can see there is a needle inserted in the breast, and in the image also you can see, and here the left side you can see the specimen mammogram where there is a lesion, the needle is being inserted, the specimen has been removed along with the needle. So the thing, some of the disadvantages are it is a painful procedure and it causes some discomfort. Sometimes we do the wire insertion in the radiology department and the patient will be shifted from radiology department to the theater. So during that shifting, the wire may get dislodged or it may move to some other place. And sometimes during the surgery, the wire may get transected. Sometimes if the transected wire may get retention inside the breast, and it may cause thermal injury because of cautery. The cautery, that is electrocautery, it may transmit the current to other breast tissues and cause thermal injury. And because of insertion, it may cause some hematoma and it may cause even syncope to the patient. So these are some of the disadvantages of the wire localizations. How to come out with this? So here, instead of using a wire localization, we can inject a small amount of nuclear radio tracer element into that, and using a handheld gamma probe or a handheld camera, we can use this thing. So it is useful in clinically occult lesion. So there is no wire inserted, only a drug being injected, the drug being uptaken by the lesion, and using a handheld camera, we can help us to take the biopsy of the lesion. So usually we can even use titanium seed containing iodine 125, and we need to have a handheld gamma camera. Here in this picture you can see the lesion is being dissected with the help of a handheld gamma camera. So this is the thing which is called as the roll technique. So coming to other things, assay, you all know about a lot of assays, like even ELISA is an assay. So assay means we measure something. So genomic assay, what is genomic assay? Genome means, genes, the arranged genes. So with this genes, we measure something. So what do we measure? So whether the patient will need chemotherapy or not, whether the patient will develop recurrence or not, whether the patient will develop metastasis or not. So three types of things are available in genomic assay. So first thing is called as Oncotype DX, which was there from the first decade of this century. So here we use 21 gene recurrence score. Here there are 16 cancer genes and 5 reference or control genes. So this is basically an RT-PCR technique. So RT-PCR we are hearing again and again. So that is called RT-PCR in COVID, but this is called RT-PCR for the gene. So here the gene expression profile is being done. So here you can see these are the different 21 genes being used, and based on that we develop the recurrence score. So if it is a low recurrence, the recurrence score is less than 18. Intermediate recurrence is 18 to 31, and high risk is more than or equal to 31. So what is the significance of this recurrence score? So here we always use women with 50 years of age and under, and usually in early breast cancer. So if the recurrence score is between 0 to 16, there is no chemo benefit. So there is no use in giving chemotherapy. But if the recurrence score is more than 26, so there is definitely a clear chemo benefit. If it is intermediate, it depends upon other factors to decide whether we have to give chemotherapy or not. So this assay, this Oncotype DX assay, helps us to identify those patients who will be benefited by chemotherapy. Why we are abstaining some people from chemotherapy? Because chemotherapy carries some amount of side effects also. So to annul those side effects, we need not give chemotherapy to such patients. So there is a advantage of this Oncotype DX. And coming to another test is called as a MAMMOGRAM. Here we use nearly 70 gene assay. It is again used for ER positive and HER2 new. And here what do we assay is whether the lesion may metastasize to other organs or not. It is a 70 gene breast cancer assay. MAMMOGRAM and Oncotype DX will be definitely there in your syllabus also. I think you can go through it. The MAMMOGRAM is introduced based on this IMPACT trial. This is a trial which used to identify the significance of this MAMMOGRAM. So another thing is called the EndoPredict. So EndoPredict, it identifies the risk of distant metastasis. So they give a score called ETHLIN score. So based on the low risk or high risk, if the score is higher, it develops into a higher risk patient, and those patients may develop distant metastasis within a 10-year period. So these are all three types of genomic assay. There is the Oncotype DX, then the MAMMOGRAM, as well as the EndoPredict. These are recent advances. Coming to the staging. So we all know about the AJCC staging, no? For all cancers, we have got this AJCC staging. Previously, it was 7th edition up to 2009. So in 2010, we had got 8th edition. So there are a lot of differences in staging of different cancers. So we'll just discuss about breast cancer. So we all know about something called DCIS and LCIS, no? So LCIS is called as a lobular carcinoma in situ. So previously, this lobular carcinoma in situ was considered as a TIS, that is it is a pre-malignant, it is considered as a carcinoma in situ, but now it is not being considered as a carcinoma in situ, but it is now identified as a risk factor for developing future malignancies. So now that LCIS has been removed from that T staging. So these are all some of the things here you can identify there. Because of more of early lesions and microscopic lesions, we have something called PTIMI. So this has been introduced in the new staging. And another thing is we have started identifying multifocal diseases also, like 2 lesions, 3 lesions. So whenever there is 2 lesions or 3 lesions, like students will get doubt which lesion, whether we have to identify the dimension. For example, a lesion with 1 centimeter and 5 centimeter is there. So we have to take it as 6 centimeter, or we have to put it as 2 lesions. So it is always, we have to put it as a multifocal lesion. We put a subscript of M, which means multifocal, and then we take the dimensions of the largest lesion. So that is the change which is being given in the 8th edition of the breast cancer staging. And another thing is, there is a definition of T4B. So T4B, we all know what is meant by T4B. One of the thing is satellite skin lesion is a criteria for having a T4B lesion. So in this, the satellite lesion must be separate from the primary tumor. So most of the time you may be seeing a satellite lesion thing just sitting over the primary tumor. So that cannot be taken as satellite lesion. The satellite lesion must be separate from the primary tumor. So these are all some of the improvements or changes which have been brought in the 8th edition of AJCC staging of breast cancer. So this we have to keep it in mind, because this may be asked in your examinations also. So this you can find out in any of your textbooks and in the AJCC standard guidelines book. So coming to my part, the recent advances in surgery. So surgical management is the most important thing and historical one. So initial thing, we all know about Halsted, who is considered as the father of breast cancer treatment. So he did the first radical mastectomy in 1894. So radical, the word itself says it is radical, it is horrible, it is gruesome, like that. But because to treat the cancer, we have to undergo such procedures. So after that, there was something called the Patey's mastectomy or chin-claws mastectomy. You all know that we call as a modified radical mastectomy. So what is the difference between radical and modified radical? In radical, we remove all the muscles of the chest wall, like pectoralis major, pectoralis minor, and even there are something called extra or ultra radical, super radical, where they remove nodes from the supraclavicular region, nodes from internal mammary. So many things when they saw that the regular radical mastectomy is not able to cure disease or causes lot of recurrence, they went ahead and did ultra radical procedures. But in spite of so much procedures, even after ultra radical procedures, patient again develops an recurrence either in the local area or in a distant area. So the Fisher's concept, Fisher is a scientist who developed the concept that this breast cancer is a systemic disease from day one. So if you continue to treat the local area, the breast alone, the other distant areas, they may develop other lesions like distant metastasis in bone, distant metastasis in lung, distant metastasis in brain, like that. So we have to give a multimodality or a systemic treatment like chemotherapy, hormonal therapy, like that, to control this distant thing. So MRM there is a modified radical mastectomy became the gold standard in the treatment of breast cancer. But after some time, we started doing even for an early lesion, like for example a 1 centimeter lesion or a 2 centimeter lesion, it was not logical to remove the entire breast. For example, a person is having a cancer in one finger. So instead of removing the finger, removing the breast is like removing his entire hand. So this was not logical. So people started doing some studies, some trials, where they started removing the particular lesion alone, giving some amount of negative margin without compromising the oncological safety. And instead of removing the entire breast, they irradiated the breast. So they used something non-surgical management for the normal breast and surgical management for the involved or the tumorous breast. So this is we call as the breast conserving surgery. So the breast is conserved, but the lesion or the cancerous part is removed, and to prevent a recurrence in the normal area, that we called as in breast recurrence. So it's called that recurrence has been reduced with the help of breast radiotherapy. So this is called the breast conservation surgery. Here there are some eligibility criteria. We need to have a margin negative lumpectomy. Here in this picture you can see how they are going to remove, and it is mainly for early breast cancer. So some of the exclusion criteria are multicentric disease, where we have 2 or 3 lesions, something like that, diffuse malignant appearing microcalcification, and prior therapeutic chest irradiations. Because for example, a patient may have got irradiation for other disease, so that is a contraindication for breast conservation surgery. And continuous positive margins and history of collagen vascular diseases and tumor size more than 5 centimeter. So these are all some of the exclusion criteria for breast conservation surgery. So the basic technique of breast conservation surgery is the incision should be made exactly over the tumor, and we remove the tumor with a margin of 0.5 to 1 centimeters, and we can even ascertain whether the negative margin has been obtained with the help of intraoperative margin assessment like frozen section or intraoperative ultrasound or a touch cytology study, something like that. And once that thing is removed, we don't drain. We don't keep a drain for the lumpectomy side. So we allow the seroma to fill that drain, and so that the breast contour is maintained. But it again had some complications like seroma formation, arm morbidities like arm swelling, phantom breast syndrome, delayed cellulitis, pain syndromes to chest wall and all. So these are some of the complications because of the breast conservation surgery. But this breast conservation surgery has highly helped to maintain the feminine figure of people. So the most commonest reason why breast cancer patients does not come to a doctor is they fear they will lose their breast. So because of that, they will hide the thing, they will delay the diagnosis, they will delay to come to the doctor. But if the women, if those females are being educated that you need not lose your breast if it is detected early because there is advancement in surgery, definitely more females, more ladies will come in early stage, and with the help of that we can conserve their breast, and as well as we can identify the lesion at an early stage. So this should be one of the thing which we have to take to the public, so that more number of people will be identified at the earliest and we can conserve their breast also. So coming to other technique, this is a sentinel lymph node biopsy. You all know what is meant by sentinel lymph node. It is nothing but the first lymph node which drains an organ, or first lymph node which drains a region. So sentinel lymph node is most commonly used in breast and melanomas. So the sentinel lymph node biopsy, it's a surgical procedure which used to determine whether the cancer has spread to the primary tumor into the lymphatic system or not. So for doing a sentinel lymph node biopsy, clinically that lymph node area should not have any lymph nodes palpable. If there are palpable nodes, there is no point in doing a sentinel lymph node biopsy. So first thing is it should be a clinically N0 axilla of the breast. So once we inject the drug, it may be a dye or it can be a radiological tracer element. So after some time, we open the axilla and see whether the dye has reached to the node. So those nodes which have become pigmented because of the dye, or which uptakes the radioactive substance, we remove that node alone. Instead of removing the entire axilla, we just remove those nodes alone and we send it for frozen study. And if those nodes are negative, we take it as all the nodes in the axilla are negative, and we need not go ahead with a formal axillary dissection. Suppose if those nodes, those sentinel nodes comes as positive, we have to go ahead and do the complete axillary dissection. So this is the advantage. So what way it helps the patient? It prevents unnecessary over treatment of the axilla. So there may be pathologically N0 axilla. So those patients need not undergo a complete axillary dissection, because axillary dissection carries its own morbidities, like surgical morbidities, like arm swelling, arm edema, and difficulty in abduction, like that. So these things can be prevented with the help of this technique called sentinel lymph node biopsy. And there is something called skin sparing mastectomy. This was developed in 1991 by Toth and Lappert. Here, instead of removing the entire breast, we preserve the skin alone, the nipple area complex and the scar sites and the skin over the tumor. All these things are removed, but the other areas of the breast skin is being preserved, so that we can maintain the normal texture or contour of the breast. So here you can see these are the various incisions used for skin sparing mastectomy. Here the most important thing is there is something called the inframammary crease. So this inframammary crease is very important on plastic surgical thing, because that maintains the contour of the breast. So we preserve that inframammary crease, and based on that we raise the skin flaps. The skin flap should not be very thin or very thick, so it should not compromise the oncological safety. So after the development of these skin flaps, the breast can be filled with either normal tissues or with some processes, or it can be even a combination of something. So the normal tissues can be latissimus dorsi flap, or it can be a tram flap or some other flap. So that will give a good texture to to there is a filling capacity for the breast, but the skin will have the normal breast skin. So this is called the skin sparing mastectomy. So these are various techniques of the skin sparing mastectomy. So coming to some of the developments in radiation. So there is something called intraoperative radiation and something called targeted radiation. So in this targeted radiation, so instead of sending the patient postoperatively after healing of wound, we place some cavitary thing. This is like interstitial brachytherapy. So through that catheter, we can inject radioactive substance so that the localized delivery of the radioactivity will be more, and because of this, the radiation exposure to other areas will be less. So the advantage is there will be immediate treatment, and it will be a short treatment, not a prolonged treatment like 4 to 5 weeks for radiotherapy unit. So another thing is the intraoperative radiotherapy. Even before closing the wound, we can place a radioactive substance inside and keep it exposed. So here the advantage is direct visualization. Here you can see in this picture, there is an intraoperative radiotherapy treatment being done. A radiotherapy ball is being kept inside the cavity. A lumpectomy has been done and radiation is being intraoperatively on the OT table itself, in the theater itself, immediately after the surgery. So some of the advantages are direct visualization of the target tissue. So immediate visualization is being done, and high risk tissue eliminating the risk of marginal miss, and use of single dose coordinated with the necessary surgical extension, thereby reducing the omission, because some people may not take radiation. We may be referring to radiation, but they may not take the radiation, and it has better toxicity profiles and is very convenient to the patient. And we may be thinking the cost will be more, but actually if you consider the cost of 5 weeks of radiotherapy, this is very, very less. And radiobiological and tumor microenvironment condition will lead to enhanced tumor control. Again, it has some of the disadvantages. In many of the centers, this may not be available, and lack of final pathological information. Like we may not be having the final histopathological report, but we'll be giving the radiation. So what are those things like tumor size, histology, margins, and nodal status? When such findings are positive, like tumor size is more, margins are positive, or nodal status is positive, we may have to give total radiation. So this is an disadvantage of having this IORT. So another surgical advance is prophylactic surgeries. So we develop breast cancer only if there is a breast. So in high risk cases, we can remove the breast tissue, not the entire breast, but the breast tissue, and reconstruct that breast tissue with some other native tissue or with some prosthesis. So this we call as mastectomies, prophylactic mastectomies. Prophylactic mastectomy can be done bilaterally. We all know about this Angelina Jolie, who had done a bilateral prophylactic mastectomy because she was a high risk candidate because of this BRCA mutation. And also in some patients, we may even do contralateral prophylactic mastectomy. So a patient develops cancer in one breast, the opposite breast, if the patient is a high risk candidate, we can remove. So this is sometimes something called as a prophylactic surgeries. So we also do prophylactic salpingo-oophorectomies also in those patients with the BRCA 1 and 2 mutations. So coming to the most important technique in surgical advance is something called as the oncoplasty. We were discussing about the breast conservation surgery. So during breast conservation surgery, we may have some instances where the symmetry may not be good. The nipple position, the nipple areola complex position may not be symmetrical in both sides. So in such cases, we have the help of the plastic procedures, that is plastic surgical procedures called oncoplasty. Here, depending upon the location of the tumor, the size of the tumor, the position of the nipple areola complex, and how the opposite breast is, whether it is pendulous or it is a straight one. So based on the shape and size and pendulous nature of the breast, we can tailor-make the incision and how much tissue has to be removed, how much tissue has to be mobilized. So these techniques are called as the oncoplastic techniques. So this is one of the recent advances in conservative breast surgery, where various plastic surgical techniques are being used to maintain the cosmetic and aesthetics of breast after a cancer treatment. Imagine, so previously we were removing the breast, the muscles, and even some areas, the bone, the nodes and all. Now we are able to treat the breast cancer without no recurrence, with very good result, as well as we are maintaining the quality of life and cosmesis. So it is not that we need to treat the disease, but we need to give a quality of life. The quality of life should be very good. so the patient is no more a patient. So the patient should become a normal person, and they should not have any post-operative complications, not only physically but also psychologically. So these are all various techniques of oncoplastic surgery, where breast conservation surgery is being combined with oncoplastic procedures to maintain the breast aesthetics. And there is something called liquid biopsy. So now there is a concept of circulating tumor cells, or nothing but called CTCs. So this is found in various other malignancies also. So there are a lot of techniques to identify these circulating tumor cells. So this is nothing but called as a liquid biopsy. We all know about solid biopsy, that is a FNAC or a true cut biopsy or an incision biopsy or excision biopsy. So this identification of these circulating tumor cells is called as liquid biopsy. So if there are more than 5 CTCs, if you identify, so then that cancer is a poor prognostic cancer. So more CTCs means more chance of distant metastasis. This is called as liquid biopsy. So here I am just reiterating the various molecular signatures. So as I was telling you earlier, luminal A and luminal B varieties are hormone positive. So they are more of endocrine dependent and chemotherapy resistant. And in other tumors like basal, that is triple negative, and HER2 positive cancers, they are endocrine resistant but chemotherapy sensitive. Here I would like to reiterate one very important point here is, almost all the treatments in breast cancer, it is sequential and not concurrent. For example, you give surgery followed by radiotherapy, or followed by chemotherapy, followed by radiotherapy, followed by hormonal therapy. So no place you have to give chemotherapy. Depends what happens in your diagnosis, and on the post-operative day 1, the patient will be given a hormonal tablet like tamoxifen, and she will be instructed you have to continue this tablet. You will continue this tablet for at least 5 to 10 years, like that. So the patient will continue the tablet, and during that time she will be sent for chemotherapy also. So when you are giving endocrine treatment and chemotherapy simultaneously, so this endocrine treatment is actually a chemo. It makes the cells chemoresistant because it is cytostatic. So a chemotherapy will function only when there is a cell multiplication. For example, you all know, you might have read in pharmacology, there are some chemotherapy drugs which are S-phase drugs, some are M-phase drugs, some enter the cell only during the metaphase, like that. So to function, the chemotherapy drugs has to function, you need the cell to replicate or multiply. So when you give an endocrine treatment, it will stop multiplication of the cells and the chemotherapy will not function. So we have to always see that when you are initiating chemotherapy, the patient is not on hormonal therapy like tamoxifen. So this has to be kept in mind for postgraduates as well as undergraduates in clinical setting. So these are all some of the targeted therapy drugs. You all know what is meant with the targeted therapy. The targeted therapy exactly acts at the target level. So HER2 is one of the most important target in breast cancer. It is also a target in stomach cancers also, gastric cancer also. So nearly 30% of tumors are HER2 positive cancers. So the first molecule which was identified and used was the trastuzumab, which acts extracellularly. So other drugs are also there like pertuzumab and TDM1, which acts extracellularly. And some other drugs like the afatinib, lapatinib acts intracellularly in the intracellular domain also. So there are a lot of advances in HER2 overexpressed breast cancer. Previously, this is very poor prognostic thing. We don't have many molecules here. So now we have got a lot of molecules. Trastuzumab can be used in adjuvant setting, neoadjuvant and metastatic. So adjuvant setting means you can give the drug post-operatively to prevent recurrence. In neoadjuvant settings, to make an inoperable lesion as operable, and also in metastatic settings. So lapatinib is another drug which is an oral tablet which can be given in neoadjuvant and metastatic setting. And pertuzumab TDM1 and can be used in neoadjuvant, adjuvant and metastatic settings. And we can even use combinations of, like, not instead of using a single HER2 blocker, we can even use combination also. Another important thing I would like to highlight is the neoadjuvant chemotherapy. So neoadjuvant chemotherapy has become the standard treatment in all locally advanced cancer. So previously we used to operate on all cancers, whether it is early breast cancer or locally advanced cancer. If there is no metastasis, we operate. But now the consensus have changed. If it is early breast cancer, you go for surgery. if it is a locally advanced breast cancer. So what is mean by locally advanced breast cancer? N1 or N2 lesions and T3 or T4 lesions. So this we call it as locally advanced breast cancer. So when there is a locally advanced breast cancer, we always go for a neoadjuvant chemotherapy. So neoadjuvant chemotherapy, you give chemotherapy drugs before surgery. So what is the goal of giving this neoadjuvant chemotherapy? It is to optimize the surgical outcome, reduce the amount of tissue being removed, and it is now the standard for all stage 3 and stage 4 cancer, and the marginally resectable tumor becomes more operable, and it is the treatment in inflammatory breast cancer. You all know inflammatory breast cancer is T4D, and it gives best outcome in pathological complete response. Like it is like having a culture sensitivity result. You put antibody, the antibiotics are being put in a petri dish where you grow the bacteria and see which antibiotic is functioning well. So like that, this neoadjuvant chemotherapy is an in vitro sensitivity of those chemotherapy drugs. So if particular chemotherapy drugs functions well, that means post-operatively you can give the same drug as a adjuvant setting. If the response is not good, means you will avoid the same drug to be given post-operatively. So these are all some of the advantages of having a neoadjuvant chemotherapy. So to summarize, we have discussed a lot of things. So to summarize, breast cancer still has a maximum advances in diagnosis and management. You see a lot of cancers, but most of the researches happen in breast cancer only. If you see the research in cancer, more than 30 to 40% of research happens in breast cancer. And there is advances in diagnosis as well as investigation. We use various biological, physical and chemical nature of the tumor cells in identifying newer diagnostic modalities, and multimodality treatment is now the standard of care in many of the cancers, and most importantly in breast cancer, which has prevented local recurrence and distant recurrence and increased the quality of life also. And the target or the aim of these advances, it is we have to give more years with less morbidity, and not only that, we increase the quality of life. The QOL is more important in cancer. We have to give a normal life after the treatment of the cancer. So molecular profiling is being given. So instead of giving a generalized treatment for all cancer patients, we are developing individualized treatment. So this patient, this particular treatment, ER positive tumors only, they will have hormone receptors, they will give hormonal drugs. If the patient is having HER2 positive, we have to give targeted therapy. So it is an individualized treatment instead of a generalized treatment. And a lot of risk stratification models are there, and risk surgical reduction techniques, like risk reduction techniques. You can have a medical reduction, like you can take some of the drugs like tamoxifen to reduce the incidence, or we have surgical risk reduction like prophylactic mastectomies, prophylactic oophorectomies to reduce the incidence of cancer in high-risk patients with BRCA mutations. So these are all some of the things we are summarizing. So this is a pandemic time. I again wish you all safe practice, both in your college, in your clinics, as well as in your hospitals. So stay safe. Thank you all. And this is my email ID and contact number. So if you have any doubts regarding this topic, you can contact me. Thank you all. Thank you.
Thank you so much, sir. Arshil? I welcome Arshil to deliver the vote of thanks. Janice?
I guess she's having some network issues.
Presentation.
I'll go with the vote of thanks.
Yeah.
Ashil, I guess you're having some network issues.
Segment is promo. Am I audible? Right. All right. You can go ahead.
Thank you, sir. That was a wonderful insight into the advancements in breast cancer treatment. With this, we have come to the end of our three-day program on breast cancer awareness. In these 3 days, we were able to connect with various experts and learn more along with our audience. We hope to conduct such useful events in the near future. We thank you, sir, for sparing your valuable time for us. Thank you again, sir. Last but not the least, I would like to thank my fellow organizers, the designing team for wonderful posters, and of course the audience for being the main fuel for the event. We extend our thanks to South Indian Medical Student Association for making this program a reality. Thank you all.
Thank you, Janice. Sir,
Thank you.
would you like to add on to something, sir?
Nothing. I just wish you all a great life ahead, good career, and congratulating you all for taking this most important issue to create awareness among the public. Thank you all.
Thank you so much, sir.